Your diagnostic methods are outdated, Dr. Chen. We need fresh approaches. Dr. Marcus Webb, the new chief medical officer, barely looked up from his tablet as he delivered my professional death sentence. Nothing personal, just modernization. My name is Dr. Sarah Chen, 52 years old, senior diagnostic physician at Metropolitan General Hospital for 19 years. I'd built my reputation on solving the unsolvable cases, the ones that stumped entire medical teams. My diagnostic accuracy rate was 94.7%, the highest in the hospital's history. But apparently, that wasn't modern enough for Dr. Webb's vision. I sat across from him in the sterile conference room, watching him scroll through what I assumed were cost-cutting spreadsheets. Webb was 39, Harvard Medical School, with an MBA in healthcare management. He'd been brought in 6 months ago to optimize clinical operations, which apparently meant replacing senior physicians with residents and AI diagnostic tools. The severance package is comprehensive, said Janet Morrison from Human Resources, sliding a folder across the polished table. 3 months' salary, plus your accumulated vacation time, and full benefits through the end of the year. I nodded, took the folder, and asked, "Is there anything else you need from me?" Webb looked surprised, as if he'd expected me to argue or threaten a lawsuit. Maybe he wanted me to give him ammunition for his board presentation about how resistant senior staff were to change. "Don't you have questions? Concerns about your patients?" he pressed. I shrugged. "You've made your decision. Seems straightforward." What Webb didn't understand was that I wasn't calm. I was calculating. There's a difference between acceptance and strategy. "We'd appreciate your assistance with the transition," Webb continued. "The new diagnostic AI system will need calibration, and your case files could help train the algorithms. Perhaps a consulting arrangement for a few weeks." "I'll consider it," I said, knowing I wouldn't. We shook hands. I cleared out my office methodically, 19 years of medical journals, patient thank you cards, and diagnostic equipment fit into 3 cardboard boxes. I nodded goodbye to colleagues who averted their eyes, afraid their specialties might be next on Webb's modernization list. As I loaded my car in the hospital parking garage, my phone buzzed. A text from Dr. James Rodriguez, the ER attending I'd mentored for 12 years. "Sarah, this is insane. Half the department is in shock. What are we supposed to do with the complex cases?" I didn't respond. At home, I sat on my back porch overlooking the city, nursing a glass of wine, watching the hospital's lights twinkle in the distance. My husband Michael placed a hand on my shoulder. "What will you do now?" he asked. "Something will come up," I replied. What Webb didn't know, what he hadn't bothered to research, was that I wasn't just another senior physician taking up salary space. I was the hospital's unofficial final diagnostic authority. For nearly 2 decades, when other doctors hit dead ends, when symptoms didn't match textbooks, when patients were dying without answers, they came to me. I started at Metropolitan General straight out of my residency at Johns Hopkins. The hospital was smaller then, serving mostly the downtown area, with a staff of dedicated physicians who knew each other's strengths and limitations. My reputation began with the impossible cases. The 34-year-old construction worker with mysterious neurological symptoms that 3 neurologists couldn't identify. I spent 16 hours reviewing his case. Noticed an unusual pattern in his blood work that suggested heavy metal poisoning, and discovered lead contamination at his job site. He recovered completely. The 7-year-old girl with recurring fevers that had puzzled pediatric specialists for months. I recognized a rare autoimmune condition that affected fewer than 1 in a million children. Early treatment saved her life and prevented permanent organ damage. Case after case, I developed a methodology that went beyond standard diagnostic protocols. I looked at the whole patient, their environment, their history, their lifestyle. I questioned everything, assumed nothing, and followed evidence wherever it led. Over the years, as Metropolitan General expanded and incorporated new technologies, I adapted. I learned to use advanced imaging, genetic testing, and laboratory analysis. But I never abandoned the fundamental principle that medicine was about understanding people, not just treating symptoms. The younger doctors started calling me the last stop, not as an insult, but with respect. When they exhausted their options, when consultants disagreed, when time was running out, they'd page me. I never minded. Each challenging case taught me something new, added another piece to my diagnostic arsenal. 5 years ago, when the hospital was acquired by the Meridian Health Corporation, things began to change. New administrators, new protocols, new emphasis on efficiency metrics over patient outcomes. My caseload was deemed inefficient because I spent too much time on complex diagnoses that could be handled by AI systems and junior residents. I pushed back, showing them the statistics. My diagnostic accuracy saved the hospital millions in malpractice suits and unnecessary treatments. I prevented misdiagnoses that could have been fatal. But the new leadership was more interested in throughput than accuracy. Michael had seen it coming before I did. "They're trying to phase you out," he warned one evening. "You need to document everything, protect yourself." I dismissed his concerns. They need physicians like me. Experience matters in medicine. "That might be exactly what they're trying to eliminate," he replied. 6 months ago, Webb arrived with his Harvard credentials and McKinsey consulting background. He immediately launched a clinical excellence initiative that emphasized standardized protocols, AI-assisted diagnostics, and reduced physician autonomy. He hired a team of young residents and nurse practitioners, equipped them with the latest diagnostic software, and began routing complex cases to them instead of senior physicians. The message was clear: technology could replace experience. I watched colleagues accept early retirement packages or transferred to other hospitals. Dr. Patricia Williams, our head of infectious diseases, left after 30 years when Webb suggested her expertise could be replaced by specialized software. Dr. Robert Kim, our top cardiologist, took a position at a competing hospital when his diagnostic decisions were repeatedly questioned by algorithm recommendations. The breaking point came 3 weeks ago when Webb reorganized the diagnostic department. He created a new position, Chief of Diagnostic Innovation, and hired Dr. Jennifer Walsh, a 35-year-old physician with expertise in medical AI systems. During the staff meeting, Webb explained the new structure. Dr. Walsh will oversee the implementation of our advanced diagnostic platform. Complex cases will be processed through the AI system first, with physician review as needed. The breaking point came 3 weeks ago when Webb reorganized the diagnostic department. He created a new position, Chief of Diagnostic Innovation, and hired Dr. Jennifer Walsh, a 35-year-old physician with expertise in medical AI systems. During the staff meeting, Webb explained the new structure. Dr. Walsh will oversee the implementation of our advanced diagnostic platform. Complex cases will be processed through the AI system first, with physician review as needed. The room was silent. Younger staff members looked uncomfortable, caught between respecting my experience and aligning with the new administration. After the meeting, Dr. Walsh approached me. "Dr. Chen, I hope we can work together on this transition. Your experience could really help train the diagnostic algorithms." I studied her face, looking for signs of sincerity or manipulation. "These algorithms, have they been tested on the kind of complex cases I typically handle?" She hesitated. "They've been validated on large datasets from similar hospitals." That's not what I asked. Our conversation ended awkwardly, but I had my answer. The AI systems were designed for common diagnoses, standard presentations, and typical patient populations. They weren't built for the cases that kept me up at night, the mysteries that required intuition, experience, and sometimes a willingness to think beyond established medical knowledge. 2 weeks after my termination, I was in my home office reviewing job listings when my phone rang. Dr. Webb's name appeared on the caller ID. I let it go to voicemail. "Dr. Chen, it's Marcus Webb. We have a situation with a complex case that's proving challenging for our new diagnostic protocols. Could you give me a call back? It would just be a brief consultation." I deleted the message and returned to my job search. 3 more calls came that day, each voicemail more urgent than the last. By evening, Rodriguez texted me. "Sarah, they've got a 16-year-old girl with multi-system failure. Nobody can figure out what's wrong. The AI keeps recommending standard treatments that aren't working. Webb's desperate." I stared at the message, imagining a teenage girl lying in the ICU, while administrators tried to diagnose her with algorithms. But I had been terminated. My expertise was apparently outdated. The next morning, Janet Morrison called. "Dr. Chen, I hope you're settling into your transition well. We'd like to discuss a temporary consulting arrangement to assist with some current cases. The compensation would be quite substantial. I picked up how substantial. $500 per hour, minimum 4-hour engagement for case review. I'll consider it and get back to you, I said, then hung up. I sat at my kitchen table, looking out at the garden Michael had planted. He joined me with 2 cups of coffee. What are you thinking? He asked. I'm thinking they're about to learn exactly what experience is worth. Over the next 3 days, the calls intensified. Webb, Morrison, even Dr. Richard Sterling, the chief of staff who had approved my termination. The 16-year-old was deteriorating. Additional cases were piling up. A mysterious cardiac condition in a marathon runner. A rare neurological syndrome in an elderly patient. A complex autoimmune disorder in a young mother. I didn't respond to any of them. On day 4, an email arrived from Dr. Elizabeth Harper, Chief Medical Officer at St. Catherine's Medical Center across town. St. Catherine's was Metropolitan General's primary competitor, known for its innovative treatment approaches and physician-centered culture. Dr. Chen, I learned about your situation at Metropolitan General. We've always admired your diagnostic expertise. Would you be interested in discussing opportunities with us? We're expanding our complex case division and need someone who can handle the most challenging diagnoses. I replied immediately and scheduled a meeting for the following day. That evening, as Michael and I were preparing dinner, our doorbell rang. Webb stood on our front porch, his usually immaculate appearance disheveled, his tie loosened. Dr. Chen, I apologize for coming to your home, but we have multiple emergency situations. Several patients are declining rapidly, and our diagnostic systems aren't providing adequate solutions. I leaned against the doorframe. That sounds concerning. It is. We need your expertise. The board has authorized me to offer you a substantial consulting fee, $750 per hour, whatever time it takes. I thought about the cardboard boxes in my garage, 19 years of medical knowledge reduced to personal mementos. I thought about nothing personal, just modernization. I thought about the young physicians who would struggle without proper mentorship. The patients who would suffer from algorithmic diagnoses. I'm sorry to hear about your difficulties, I said quietly. But I have an interview tomorrow. I'm sure something will work out. I closed the door on his stunned expression and returned to dinner preparation. For the first time since my termination, I felt a sense of clarity wash over me. I wasn't going to rescue the system that had discarded me. The interview with Dr. Harper exceeded my expectations. We met at a quiet restaurant downtown, away from both hospitals. I've followed your work for years, Harper said over coffee. Your diagnostic methodology is legendary among senior physicians. That case study you published on environmental toxin detection, it's required reading in our residency program. Thank you. It took years to develop that approach. That's exactly what I want to discuss: experience, methodology. The art of medicine that can't be programmed into algorithms. Harper leaned forward. We're creating a new position, Director of Advanced Diagnostics. You'd have a team of junior physicians, access to the most sophisticated testing equipment, and complete autonomy to handle our most complex cases. I was intrigued. What's the catch? Harper laughed. No catch. We believe that the future of medicine isn't about replacing physicians with technology, but about giving the best physicians the best tools. Your salary would be 25% higher than your Metropolitan General compensation, plus research funding and teaching opportunities. It was an exceptional offer, almost too good. Why me? I asked. There are other experienced diagnosticians available, because we tried the algorithm approach. Hired consultants, implemented AI systems, followed all the current trends. Our diagnostic accuracy actually decreased, and our most complex cases started going unsolved. We realized we needed someone who could think beyond the programming. I accepted the position that same afternoon. Meanwhile, Metropolitan General's crisis was deepening. Rodriguez kept me updated through brief texts. The 16-year-old had been transferred to another hospital after her condition worsened. The complex cases were overwhelming the junior staff. They'd brought in expensive consulting physicians. But without access to my case files and methodology, they were essentially starting from scratch with each patient. A week after I started at St. Catherine's, Webb called again. This time, his voice had lost all pretense of authority. "Dr. Chen, please. We have 3 critical cases, and our consulting physicians can't establish diagnoses. Patients are dying." I was in my new office, reviewing a fascinating case of suspected genetic mutation. "I'm sorry to hear that, Marcus. I'm committed elsewhere now. We'll triple whatever St. Catherine's is paying you, just for consultation on these cases. It's not about money, then what? Revenge. Are you enjoying watching patients suffer because of administrative decisions?" I paused, carefully considering my response. "No, Marcus. I'm not enjoying patients suffering. But you made a business decision. You decided that AI could replace clinical experience. Now you're discovering what that actually means. The board wants to discuss bringing you back. Full salary, restoration, plus a significant bonus." For a moment, I felt a flicker of vindication, but it passed quickly. Returning would solve nothing. The same executives who had determined I was obsolete would be waiting for the next cost-cutting opportunity. "I appreciate the offer, but I've made a commitment to St. Catherine's." Webb's tone hardened. "You know there could be legal implications if we discover you're withholding medical knowledge that could save lives. Professional ethics violations." There it was, the threat I'd been expecting. Every piece of medical knowledge I possess was developed through my education, training, and experience. I've taken nothing proprietary from Metropolitan General, but feel free to have your attorneys contact mine. I hung up, hands trembling slightly. Not from fear, but from anger I'd been suppressing. The accusation that I was somehow responsible for their failures was the ultimate insult. At St. Catherine's, I was building something better. A diagnostic program based on mentorship, thorough investigation, and the integration of technology with human insight. I wasn't looking back anymore, but I also wasn't going to rescue the system that had abandoned both its patients and its principles. A month into my new position, I received an unexpected visitor. Dr. Rodriguez appeared in my office doorway, looking exhausted and defeated. "Got time for lunch?" he asked. Over sandwiches at a nearby cafe, James filled me in on the chaos at Metropolitan General. "It's worse than you know," he said, lowering his voice. "They've lost 3 patients in the past 2 weeks. Cases that you probably could have diagnosed in your sleep." I wasn't entirely surprised. The cases Webb had described matched patterns I'd seen dozens of times. Rare conditions that required experience to recognize. Environmental factors that algorithms couldn't account for. Genetic variations that didn't appear in standard databases. "There's something else," James continued. He pulled out his phone and showed me a series of internal emails he'd discovered. Webb had been planning to eliminate senior physicians for months. He convinced the board that AI could replace diagnostic expertise within a year, projecting cost savings of over $2 million annually. I read through the emails, feeling a familiar detachment. One message from Webb stood out. "Dr. Chen's diagnostic methods are intuitive, rather than evidence-based. She's created dependence on her personal expertise, rather than teaching transferable skills." "The worst part," James said, "is that Meridian Health Corporation is planning to sell Metropolitan General. They've been preparing for this for over a year." Webb was brought in specifically to reduce costs and make the hospital look more profitable. Everything made sense now. The push for standardization, the resistance to senior physician input, the sudden emphasis on efficiency over accuracy. It wasn't about improving patient care, it was about maximizing profit margins for a quick sale. "Why are you showing me this?" I asked. James closed his phone. "Because I'm resigning next week. So are Patricia Williams and Robert Kim. They're both coming back from their new positions to start a private practice. We want to know if you'd be interested in joining us." That afternoon, I discussed the private practice offer with Dr. Harper. She was surprisingly supportive. "If you're interested in that direction, I understand," she said. "But I have another proposition. What if we created a diagnostic consulting service through St. Catherine's? You'd work with multiple hospitals, handling their most complex cases, while maintaining your position here." It was intriguing. What would that look like? "You'd head a team of senior diagnosticians, physicians like Rodriguez, Williams, and Kim. We'd contract with hospitals that need expertise, but can't afford full-time specialists. It would be like having the best diagnostic minds available on demand." The idea appealed to me. instead of just moving to another hospital. We could create a new model that preserved the value of clinical experience, while making it accessible to more patients. That evening, I called James. What if instead of a private practice, we created something bigger? A diagnostic consulting group that could work with multiple hospitals. 2 weeks later, Dr. Harper announced the formation of the Advanced Diagnostic Consortium. Rodriguez, Williams, Keem, and 3 other senior physicians I'd recruited would provide specialized consulting to hospitals throughout the region. St. Catherine's would serve as our base, but we'd travel wherever complex cases required our expertise. Our first client came sooner than expected. 6 weeks after the consortium's formation, Dr. Harper called me into her office. I just received an interesting call from Dr. Richard Sterling at Metropolitan General. Sterling was the chief of staff who had approved my termination. What did he want? They have a case that's stumping everyone. A 28-year-old software engineer with progressive neurological symptoms. Multiple consultants, extensive testing, and their AI system can't establish a diagnosis. The patient is deteriorating rapidly. I considered the situation. What exactly is Sterling requesting? A consultation through our consortium. He specifically asked for you, but emphasized it would be purely professional. No mention of your previous employment there. It was tempting to refuse, but a patient was suffering. That had to be my priority. What are the symptoms? They're sending everything over this afternoon. That evening, I reviewed the case files in my home office. The patient, David Coomer, was a 28-year-old software developer with no significant medical history until 6 months ago. His symptoms had begun subtly, mild fatigue and occasional muscle cramps, but had progressed to severe weakness and cognitive impairment. The more I read, the more familiar the pattern became. Multiple specialists had tested for common neurological conditions, autoimmune disorders, and genetic diseases. All negative. The AI diagnostic system had suggested various treatments based on symptom clusters, but nothing had helped. Then I found it, a detail buried in the occupational history that everyone else had overlooked. David had started working for a new company 8 months ago, developing software for industrial applications. His office was located in a converted warehouse that had previously housed manufacturing operations. I called Dr. Harper. I need environmental testing data from the patient's workplace, specifically heavy metal contamination analysis. The AI system already considered environmental factors, she replied. Did it consider the specific metals used in electronic component manufacturing 40 years ago? Did it cross-reference the building's industrial history with the patient's symptom timeline? There was a pause. I'll make the call. The environmental testing confirmed my suspicions. David Kumar's workplace contained elevated levels of organic mercury compounds, residue from decades-old industrial processes that had never been properly remediated. His symptoms were consistent with chronic mercury poisoning, a diagnosis that required knowledge of industrial history, environmental medicine, and the long-term effects of low-level toxin exposure. The AI system had never been trained on this specific combination of factors. It couldn't make the connection between a modern software company and historical industrial contamination, because that link required human experience and intuitive reasoning. Within 48 hours of beginning chelation therapy, David's symptoms started improving. Within 2 weeks, his cognitive function had returned to normal, and his muscle strength was steadily increasing. Dr. Sterling called personally to thank me. That was extraordinary diagnostic work, Dr. Chen. Our entire team learned something valuable from this case. It was pattern recognition based on experience, I replied. Nothing that couldn't be taught to junior physicians with proper mentorship. About that, Sterling said. I'd like to discuss expanding our consulting relationship with your consortium. We're finding that certain cases require the kind of expertise that can't be programmed. After I hung up, I felt a quiet satisfaction. Not vindication or revenge, but the simple pleasure of knowing that experience and careful reasoning had saved a young man's life. Word of David Coomer's case spread quickly through the medical community. Within 2 months, the Advanced Diagnostic Consortium had consulting contracts with 12 hospitals across 3 states. We were handling cases that other institutions couldn't solve: rare genetic conditions, environmental toxin exposure, complex drug interactions, and unusual disease presentations. Each case reinforced the same lesson. While AI systems were excellent at pattern recognition within their training parameters, they couldn't replace the intuitive leaps, cross-disciplinary thinking, and experiential knowledge that came from decades of clinical practice. One morning, I received a call from Dr. Jennifer Walsh, the Chief of Diagnostic Innovation, who had replaced me at Metropolitan General. "Dr. Chen, I wanted to apologize for how your departure was handled. I've learned a lot in the past few months about the limitations of algorithmic diagnosis." "What's happened?" I asked. "We've had several cases that our AI system couldn't solve. When we consulted with your consortium, your team identified diagnoses that none of our technology had considered. I'm beginning to understand what you meant about the intersection of different factors in each patient." I appreciated her honesty. AI is a powerful tool, but it's just that, a tool. It should augment physician judgment, not replace it. That's exactly what I wanted to discuss. Would you be willing to help us redesign our diagnostic protocols? We want to create a hybrid approach that combines AI capabilities with senior physician oversight. It was an interesting proposition. Instead of replacing the flawed system, we could help rebuild it properly. "I'd be willing to discuss it," I said. "But any protocol would need to include proper physician training, case-based learning, and respect for clinical experience." "Absolutely. We've learned that lesson." 6 months later, I stood in the conference room at Metropolitan General, addressing the medical staff about the new integrated diagnostic protocols. The room was packed with physicians, residents, and nurses, many of whom I'd worked with for years. Dr. Harper had agreed to let me split my time between St. Catherine's and consulting with Metropolitan General's diagnostic redesign. It wasn't about returning to my old position, but about creating something better. The new protocols combine AI analysis with mandatory senior physician review, I explained. The technology identifies patterns and suggests diagnoses, but experienced physicians evaluate those suggestions in the context of each patient's unique circumstances. A young resident raised her hand. "How do we know when to trust the AI versus our clinical judgment?" "You don't choose one over the other," I replied. "You use both. The AI provides data-driven insights based on large datasets. Your clinical experience provides context, intuition, and the ability to recognize patterns that don't fit standard categories. The best diagnoses come from integrating both approaches." After the presentation, Dr. Webb approached me. He looked different, less arrogant, more genuinely interested in learning. "Dr. Chen, I owe you an apology. I underestimated the complexity of diagnostic medicine and the value of experience. I hope we can work together going forward." I studied his face, looking for sincerity. "Experience isn't the enemy of innovation, Marcus. It's the foundation that makes innovation meaningful." I'm beginning to understand that. 1 year after my termination from Metropolitan General, I received an invitation to speak at the National Conference on Diagnostic Innovation. The topic: integrating artificial intelligence with clinical experience. Standing at the podium, looking out at hundreds of physicians, administrators, and technology experts, I reflected on the journey that had brought me here. The future of diagnostic medicine isn't about choosing between human expertise and artificial intelligence, I began. It's about understanding how they complement each other. AI systems excel at pattern recognition and data analysis. Human physicians excel at contextual understanding, creative thinking, and recognizing exceptions to the rules. I told them about David Kumar, whose mercury poisoning would never have been diagnosed by algorithms alone. I described cases that required not just medical knowledge, but understanding of human psychology, environmental factors, and social circumstances. Experience matters, I continued, not because it makes us resistant to change, but because it gives us the wisdom to know when to trust new tools and when to rely on time-tested methods. After my presentation, a young physician approached me. "Dr. Chen, I'm starting my residency next year. How do I prepare for a medical landscape that's constantly changing?" I smiled, remembering my own early years of uncertainty and ambition. "Learn everything you can about both the art and science of medicine. Master the technology, but don't let it replace your curiosity. And remember that every patient is a unique puzzle that requires both data and intuition to solve." Later that evening, I sat in my hotel room, looking out at the city lights and thinking about the path that had led me here. I hadn't sought revenge against those who had undervalued my experience. I hadn't needed to. Instead, I'd focused on building something better, something that honored both innovation and expertise. My phone buzzed with a text from Michael. "Saw your presentation online. Proud of you. Come home soon." As I prepared for bed, I felt a deep sense of satisfaction. Not because I'd proven anyone wrong, but because I'd proven that good medicine, like good diagnostic reasoning, requires both cutting-edge tools and timeless wisdom. The Advanced Diagnostic Consortium now works with over 30 hospitals. We've saved hundreds of lives by solving cases that might otherwise have remained mysteries. More importantly, we've trained a new generation of physicians who understand that the future of medicine lies not in replacing human expertise, but in amplifying it. Sometimes the best response to being undervalued is simply to demonstrate your worth elsewhere and let the results speak for themselves. In medicine, as in life, quality work done with integrity eventually finds its place.